Inagural, como saben, es el doctor Barrabés, presidente de la sección de cardiopatía isquémica. Yo soy el doctor Pablo Avanzas, miembro del comité organizador local y trabajo aquí en el Hospital Central de Asturias. Yo simplemente pues darles la bienvenida y que estamos encantados de que el congreso se celebre aquí, de recibiros a todos en esta ciudad, y yo creo que sin más, que llevamos mucho retraso, paso la palabra al doctor Barrabés.
Gracias, Pablo. Thank you. It's my pleasure to introduce Dr. Harlan Krumholz, who is going to present the opening lecture of the symposium. It is a very high honor for us having you here. Dr. Krumholz is a very well-known scientist and friend for all of you. He's a full professor at Yale Medical School. He's the director of the Care and Outcomes Research Evaluation Unit at Yale. He has an impressive curriculum. It is difficult to open a circulation number without seeing his name in print. And he is one of the founders of the Council on Quality of Care and Outcomes of the American Heart Association, which is celebrating its annual conference just at this moment. And we are particularly thankful to you because of your effort of being here instead of being in your meetings. Thank you very much, Harlan.
Thank you, Pepe. It's a great honor for me to be here. Actually, my 6th meeting with you. And every time I come, it feels a bit like a family reunion, to be among friends, to be back in Spain. It's true that the meeting that I started, and for many of my friends in the U.S., is being conducted now, but I couldn't imagine not returning to be part of this meeting. It's a very important one to me. In fact, maybe one of the highlights of my career is to participate in this meeting every other year, to come back to Spain and to be able to share ideas with friends. Cada año mi español es un poco peor y peor. Pero maybe I need to spend more time in practice. But it's always a distinct pleasure to be here, and I just want to thank you. Also, my father's with me, and so it's also a special trip to spend a week in Spain with my father in medicine because of him. He's a physician also, and it's a nice opportunity for me, and one that I also thank you for that opportunity as well. This is a talk. I wanted to know, Pepe, when did you graduate from medical school? In 88? 86? Yeah. So I was doing this research about what's going on in Spain, and as I was going on, I was looking at this dramatic decline in CHD death, and I thought, well, maybe Pepe is responsible for this. Because I wanted to just start my talk with a great salute to Spanish cardiology, because it seems as if you've experienced quite a dramatic decline in CHD mortality and in ischemic heart disease, more or less over the period of these conferences. And since Pepe and Hector graduated from medical school, it's quite astounding. But look at these remarkable improvements that have occurred from 1988, and this is I got to 2005 in an article that was just published in Magda's Journal in 2011. Quite a nice accomplishment for the group. But I'm not here only to praise Spanish cardiology, but to also challenge you to think about some new ideas. And I was asked, well, what is this talk about anyway? Because the title seems quite mysterious to some people. And so I wrote to Pepe that practitioners and guideline writers often assume that modifying risk factors is equivalent to modifying patient risk. But a growing literature casts doubt on that simple assumption, revealing a truth that's much more complex. This lecture will review the evidence for risk reduction and discuss the implications for current practice and future research. So I really don't seek to only go at windmills. I really want to question dogma. And although I won't say it's the same as Galileo, I think that we must question the assumptions under which we operate consistently if we are to advance as a field. What are our goals in cardiology or in medicine or in any areas of public health? Well, we seek to promote healthy communities, optimal care and outcomes, and affordable care. This is the so-called triple aim, the areas in the U.S. that we're focusing on with great intensity. But in them, embedded in them, is the idea that we care about the results. We care about what we're producing, not just being able to talk about utilization or treatment patterns, but we care about the results that are actually being achieved, the lives that are being saved or benefited as a result of our work, or the cost, the waste that can be avoided. I'm going to focus this talk in the beginning on the area of cholesterol, only because it is an example, at least to start, not because I'm exclusively interested only in this topic, but it serves as a, I think, useful area to begin. This is a very famous relationship that has been described many times and in many places. This comes from Framingham, but it could have derived from many other places as well, and shows the relationship between total cholesterol, and of course this is from early on, so they're measuring total cholesterol, and CHD incidence, in this case per 1,000 per year. But the nature of this relationship has been shown that higher cholesterol represents higher risk. And this is an epidemiologic relationship. It's one that shows that the cholesterol level is predictive. You can use it to stratify risk, to predict risk. And that kind of work led in the 1970s and 1980s to a great enthusiasm for treatment of cholesterol in the U.S. and a great vilification of cholesterol in Time magazine as an example of that. And that also led to a notion of targets, of identifying targets for treatment, so that as physicians, we are trained to titrate levels of risk factors in order to produce benefit in patient risk. This became very much part of our teaching, of our practice. In fact, in the United States, we were being judged how good of doctors we were based on how well we were able to hit targets for cholesterol. By the way, also for blood pressure or hemoglobin A1C or a wide variety of other risks. Now, these famous curves, and this is another one which basically looks at by age and shows that these relationships are steeper with younger age, but at all the ages, even 80 to 89, the cholesterol level could be predictive. And these kinds of relationships led in 1988 for the U.S. government to produce guidelines. This is very unusual, by the way, for the U.S. government to produce guidelines. The National Cholesterol Education Panel. And this represents the very first one. And embedded in this were the targets. What we as physicians, how we should be treating our patients, how we should be titrating the levels of their risk factors. Interestingly, what they said was in developing the report, the panel followed two basic principles. One was simplicity, to make the guidelines as simple as possible. The second principle was to provide enough detail to assist physicians and healthcare professionals in dealing with individual patients. The question is, as they focused on targets and simplicity and these algorithms for doctors to follow in order to treat their patients, did they forego the principle of adhering to evidence? Did they adhere to evidence sufficiently? And that's a question I'll be asking. Meanwhile, we promoted to the public big campaigns about these targets. We said to patients in advertisements like this, do you know your cholesterol levels? Healthy hearts, healthy homes. In airports, on billboards, throughout the areas, the American Heart Association and others would take out public service announcements that would say, know your number, know your number. This was going to be the key to heart health. Now, in Spain, it seems, there's also been interest in this issue. And like in the United States, there have been studies. This one also published in a very famous journal is one that was, in fact, only in online, not even in print yet, showing knowledge, treatment, and control of hypercholesterolemia in Spain, 2008 to 2010, a study that was sponsored by Sanofi and undertaken by Spanish cardiologists. And interestingly, Sanofi without an anti-cholesterol, low cholesterol-lowering drug, but this is what we had. And you saw what percent of the Spanish people who had hypercholesterolemia knew about it, were on treatment, and were controlled. So you too are receiving information about the inadequacy of treatment, about how people aren't being treated sufficiently to targets, and how this represents a quality issue in Spain, in the same way that we are in the United States. Now, I'm going to take a slight detour because as I was learning about this and studying Spain, I learned some things that were quite interesting to me. This article, the one previously, same one, what they said in the discussion was the prevalence of hypercholesterolemia in Spain is similar to that of the United States in 2006 and in the UK in England in 2003. Interestingly, mortality from ischemic heart disease is much lower in Spain than in the United States and in England. So even though you lag in your cholesterol treatment and in your cholesterol levels, you actually have lower levels. And it led me to wonder, when I look at this, is this an immutable relationship? Is this a relationship that stands across all groups, in all settings, in all countries? Or does this vary by countries? Because it seems as if its predictive value is different in Spain than it would be in England or in the United States. Now, this is the hypercholesterolemia in the Spanish population. The way they measured it is either elevated LDL or under treatment. And it was interesting to see the places where it is there is more hypercholesterolemia in the northern areas of Spain more than in the southern. Andalusia has maybe the lowest level of hypercholesterolemia. That's interesting. Maybe you already know that. Maybe that's diet. Maybe that's quality of care. Depends where you're from, I guess. But look at this. Age-standardized mortality from ischemic heart disease in European regions. Red is the highest. Green, the darkest green, is the lowest. Well, of course, you know that this region of the world has the lowest ischemic heart disease mortality. But also look, where is the lowest in Spain? Actually, in these regions. And this is low, but not as low as here. And if you remember from this, many of these areas with the highest levels of cholesterol in Spain also have the lowest mortality. It was quite a strange finding, so I looked a little bit harder. I'm going to finish this detour in a minute, but I thought it was kind of interesting. I found this from the European Heart Journal, May 3rd, 2012. You know, I only prepare for talks at the last minute. So these are all very current articles. And look at this article. This is showing 25-year CHD mortality rates in different cohorts in the 7-country study. Northern Europe, United States, Southern Europe, inland, Mediterranean Southern Europe, Serbia, and Japan. Look at this. The curves have a very different nature to them depending where you're from. And I was particularly interested in Spain, which is the Mediterranean Southern Europe. Is that right? Okay. I just want to be sure. Mediterranean, it's a fairly flat curve compared to Northern Europe or the United States. In fact, when I began thinking, I wonder if these curves vary based on place, then I suddenly found this article, which just came out last week, emphasizing that these relationships are not the same everywhere. So the epidemiological relationship changes. Now, is it biology, setting, habit, behavior? But this is a very powerful finding, I think, to suggest that, and also, by the way, in your ESC guidelines, where you estimate risk, they have a risk score for high-risk countries and a risk score for low-risk countries. But maybe even the power of individual risk factors may vary based on the country itself. And this speaks to, I think, understanding mechanism, but may have implications for treatment as well. I just found this a fascinating article. And what are the implications if it's this flat? Because you're really only talking about mortality rates between 3 and 6%. I mean, it is a doubling, but it's a very low absolute difference between the low and high cholesterol groups in these countries. And it led me to ask this question, by the way. Maybe you know, this will be my last of the detour. But this is the question I have. How many of the large pivotal cholesterol-lowering trials, how many patients were enrolled in Spain? How much evidence do you have in Spain of the effect of the treatments that were demonstrated for us? That's Northern Europe. West of Scotland, I think that's Northern Europe. Many of the other cholesterol-lowering drugs trials were conducted probably with not many patients in Spain enrolled. Not many patients from the area where that curve is so flat. I wonder if it would be worth pooling the data from these countries to understand how the effects are. I haven't seen that subgroup. Maybe you have. But it occurred to me to ask. So I want to get back to the main thrust of this talk, which is about targets. And the question of no matter where you live, even if you assume that you're on the steep part of the curve, even if you assume that these relationships exist here as they are. By the way, this isn't Spain, nor is this. But if you take LDL, this is total. Same would be for LDL. Over time, you've got this. Or HDL. The higher the HDL, the lower the risk. The target supposition, the target assumption is that if I move you from here to here, then I move you from here to here on the curve. It says we understand the epidemiological relationship and modifying the risk factor, moving the risk factor will move patient risk. It's an inherent assumption, which is different from saying in the wild, looking at the population, I can predict risk based on the cholesterol. The target believes I can move you on the curve. And if I move you down, your risk will go down. So let's explore that a little bit. It's a key critical question, both for HDL, total cholesterol, or LDL. And by the way, this led some people to write articles like this, to say the optimal LDL is 50 to 70. They are saying, let's move you down the curve. In this article, they suggest that if we can get people to 30, we will have 0 events. They say they just take the curve all the way down. But many drugs that lower cholesterol actually increase risk when used in trials. Many of the early treatments that were used, particularly these, clofibrate, dextrothiroxine, estrogen, and torcetrapib, there are medicines that would move your risk factor, but actually move the risk in the wrong direction, or leave the risk alone. Now, torcetrapib is an interesting example. This is from the Illuminate trial. Now, you know there was a lot of enthusiasm about this drug. Now, just to remember, this drug is pretty terrific at changing risk factors, at moving the risk factor. How good is it? This is the percent change at 12 months. In HDL, the drug increased by 72%. The HDL. The placebo, virtually unchanged. The remarkable thing about this drug was, not only did it increase HDL, but it decreased triglycerides and LDL. Triglycerides go down. Placebo about the same. LDL went down 24%. Better than a lot of statins will do for you. 24%. Placebo doesn't change much. People's lab tests looked spectacular. People's risk factors improved. They were modified favorably. And as you remember, the patients without event, death from any cause, this drug was associated with higher mortality, lower survival. People died on this drug. And whether you looked at major cardiovascular events or death from any cause, it was hazardous. If Pfizer had not done this trial, we would never have known. Because even this size harm would have been hard to detect in practice. I asked the FDA, was Pfizer required to do this trial? Bob Temple told me no, they weren't. They would have been approved based on the favorable modification, the presumed favorable modification of the risk factor. They did this because they were so confident in the result, or they were so responsible, one of them, and there was a big surprise. Now, it's easy to say, and we've heard very much, that this was because of off-target effects, unexpected harm in a drug that offset the benefit. It reminded us of a CAST trial, where we were led astray when we used flecainide and encainide to suppress premature ventricular contractions in patients after myocardial infarction. They looked great in the CCU. The extra beats were quieted. We were reassured. I trained in a place that was using a lot of this medication just before CAST. And we were convinced it was a miracle drug. You gave this drug and the PVCs went away. And we were very happy. Until this trial came out and showed us that we were killing people. That we couldn't tell, but we were increasing risk. And this is a very early study reminding us of the concerns about surrogate endpoints. Because ultimately, the risk measures, like cholesterol, are surrogate endpoints. They're not outcomes that patients experience. They are markers. We believe they're markers of risk. We assume that if those markers of risk are favorably treated, then the patient will do better. But these surrogates can lead us astray. They do not always align well with patient outcomes. It's a shame because the surrogates help us do studies faster and cheaper. We don't have to wait for events. We don't have to enroll so many people. But we are finding that this is unreliable. Now, this was an interesting week for this drug, these cholesterol ester transfer proteins. What happened here was, by the way, you'd see Pfizer invested $800 million. They were projecting a $10 billion drug, a blockbuster like no one has ever seen before. They were very disappointed. But then there was this I took from an article in Nature Review Drug Discovery that was showing how you start with Pfizer being upset about this finding, but this class continuing in its development as torcetrapib is identified as a drug that had bad properties. But again, there was a lot of confidence that they figured out why torcetrapib had a problem. Some people supposed it was because it raised the blood pressure 1 or 2 points. That's a big stretch to think 1 or 2 points was responsible for increased mortality, the aldosterone effect. So Roche and Merck proceeded forward, Lilly. You know this story this week, but some very prominent, including the editor of the European Heart Journal, was conducting studies for Roche, and they were saying, this is a safe drug. You don't have to worry about it like we did torcetrapib. It's very safe. Articles came out. Elevating HDL cholesterol levels with dalcetrapib is safe. It doesn't have any of the problems that torcetrapib has. We can be relieved by this. We can be reassured that it doesn't bother the vasculature. It doesn't raise the blood pressure. It doesn't have any of those problems that torcetrapib had. But then this week, you all know, because even you had a satellite symposium conference that was dropped because it was on HDL by Roche. And this week they decided to stop all development of the drug. They didn't just stop one trial. They have given up on this drug based on the data safety monitoring information that we don't have yet. We're told it's not harmful, but I'm curious to see what happened that would have led them to such a dramatic decision. But the headlines: Roche drops after halting drug development. Roche terminates development. It was all over the news. And this is a big deal. Because again, this drug increased HDL 30-40%. It should have favorably modified patient risk. Apparently, the evidence is so strong that this drug is not beneficial, that the hundreds of millions of dollars that they put into this drug, they're willing to write off now. And I commend Roche for making the decision, because I assume that the evidence is sufficiently strong to decide not to put more money into this drug. But this is a big deal. This is, again, reinforcing the same idea that modifying a risk factor does not equate to modifying risk. Now, there are other drugs still in development, anacetrapib, and so we'll see. But this is my point. I hope they're successful. But this is reinforcing the need to actually test in patients whether our strategies are beneficial. In the U.S., we've been approving drugs for a long time because they modify risk factors without testing for their effect on patients. Even within the same class. Notice torcetrapib and dalcetrapib, same class as anacetrapib. We're trying to see, can we find a drug in this class that works? We can't necessarily assume across a class that they're going to have the same effect or the same risk profile. Now, I want to give you some other examples about this. I don't, by the way, have any disclosures. I'm not paid by any drug companies, and probably especially won't after this talk. But I wanted to go through a few. This is Abbott's drug, Niaspan. This is an ad that we see all the time. Help patients get to higher HDL-C levels. This drug is approved in the U.S. Why? Because it favorably affects a risk factor. How many trials of this drug have been shown to reduce patient risk? So far, none. So far, none. Now, I always say so far. You can only make a decision based on what you know now. It was studied in the AIM-HIGH study. It's gotten some criticism, AIM-HIGH. As you know, HPS2 Thrive is also in, we're waiting for results from the Oxford group on that. It's probably another year or so away of a different formulation, a different intervention arm. But in AIM-HIGH, niacin in patients with low HDL receiving intensive statin therapy. In this study, HDL went up 25%. Interestingly, the placebo HDL also went up. Triglycerides went down almost 30%. LDL went down about 12%. The risk factors were favorably impacted, as expected. The drug did what you expect to do. It was on top of intensive statin therapy, but we treat a lot of our patients with intensive statin therapy, especially like these patients. And you all know the result. Much better risk factors. The risk factors look great. It did what it was supposed to do. The patients didn't do any better. Patients did the same. Meanwhile, in the U.S., this is a study that we did looking at sales. You know, this is a $1.4 billion drug in the United States. And in the absence of any evidence between 2002 and 2009, we've given more and more of it every year. We're a wealthy country. What's $1.4 billion? It matters to us. It matters to us. We're not that wealthy. We can just do that. But as I said, the drug is approved because of what you saw on the risk factor slide. On the patient outcome slide, that wasn't a requirement for approval. And with promotion, the drug goes over $1 billion. What about fenofibrate? This is, I took at the American College of Cardiology. Even on top of cabs, we're welcomed by the makers of fenofibrate. They should welcome us. They have a lot of money. How many studies of fenofibrate are there that have tested its effect on patients? 2. How many have been positive for the primary endpoint? 0. But it was approved because of its favorable effect on risk factors. This is, I think, the best study. The other study is called the field study. This is a cord in diabetics, high-risk group. The fenofibrate reduces total cholesterol a little bit. Interestingly, no effect on LDL. I actually expected it to have a little bit of effect on LDL. Raised HDL. This starts at the beginning and over the years. The red is fenofibrate, so it's at every time point fenofibrate is, the HDL is higher. And the triglycerides are markedly lower. It does what it's supposed to. It does what it was approved to do. It does what the FDA required it to do to approve it. Only one little problem. Outcomes? Exactly the same. Primary outcome, macrovascular outcome, death from any cause, death from cardiovascular cause. Can you think of any cause that might be better? The patients had better risk factors, no difference in their outcomes. It's a familiar story. And by the way, this is a $2 billion a year drug. And here's what's happened in the United States since 2002 to 2009. This is all fibrates. We give more and more and more. When the field study comes out that's negative, we don't stop. We keep giving more and more and more. And it's all fenofibrate. By the way, very little generic. 90% is proprietary in the United States. That's another story why that happened. We wrote about that, if anyone's interested. But $2 billion, 2 negative studies, no evidence that it's flagging, very strong marketing. Then we have drugs like this, Vytorin. This is a very nice ad. Cholesterol comes 2 sources, food and family. Then they had these people look like the food. It was very cute. This was a $5 billion a year drug. How many trials? It favorably impacts LDL. How many trials, outcome trials have been completed of Vytorin, of ezetimibe versus placebo? 0. The SHARP study was simvastatin plus ezetimibe versus placebo. So there was no simvastatin plus ezetimibe versus simvastatin, so you can't tell. And the trial that's going to come out will come out maybe in 2 years after this comes off patent. It's being run by Timmy and Duke, I think. Meanwhile, this shows you we prescribed it more and more and more. It was ultimately a $5 billion a year drug. It modified risk factors. We don't even know. We don't even have a study yet to say what it is on risk. It did what the FDA asked it. It lowered LDL. Meanwhile, new drugs come out. We just have these antisense article that was in the New England Journal, phase 1 study, suggesting that we can lower cholesterol by new and novel ways. And the ads are already starting to prepare us for a drug that may be approved. Now, the FDA may be getting wiser and require an outcome study now. But we're being prepared again to think about only risk, lowering LDL, and novel targets to achieve novel targets. This is now talking about drug targets to achieve new levels, which is the LDL targets. How is this possible? Does this mean we don't believe in the underlying mechanism, that we don't believe in the cholesterol hypothesis? Not at all. This is not a debate about the cholesterol hypothesis. I was in an argument with someone about a guideline recently and was trying to explain this fact. That's why I want to make it to you. And I explained that we shouldn't be doing what we've always done. And he said, don't you believe in the cholesterol hypothesis? I said, that is beside the point. Let's say I do. And by the way, I believe that cholesterol is an underlying mechanism of cardiovascular disease, atherosclerosis. I don't doubt it. But if I've got a patient and I've got an outcome and I make an intervention, well, if that intervention affects a surrogate like lowers LDL, right? And I think this is on the pathway, the mechanistic pathway. It's not just a marker of risk, but it's in the mechanistic pathway. And now I'm giving a medicine that's going to interrupt that mechanism. The problem is this. Every drug you give has more than one effect. What you're seeing reflected in the biomarker, the LDL, the surrogate, is only a reflection of one of the things it may do. These drugs may have other effects. And the interventions may go from the patient straight to the outcome, not even measured by the surrogate. And there may be thousands of effects. Fibrates affect transcription. They affect nuclear DNA regulation. They affect PPAR alpha. These are they're like the TZDs. I mean, they're related. They have many different effects. Our ability to predict what will happen to patients is more limited than you might think. And this is why we're getting into trouble. Not because we may not be able to say not only is this a predictive factor, but it's in the mechanism. But the question is, what's the net effect of the drug? So going back to targets. We have a very strong predilection to say you should be treating to target. How many pivotal cholesterol-lowering trials tested the efficacy of a target? How many cholesterol trials had an intervention that was treating to target? How many? Zero. There's not one trial of treating to target. They're all fixed drug trials. Now they have inclusion criteria that are based on cholesterol levels. But once you get into the trial, these are not trials of strategies of treating to target. They are trials of fixed drug doses. This trial is a fixed drug trial. If you're in the active treatment arm, you get a pill. You don't get a pill and then they test your cholesterol and then they intensify and they add on different agents and they see what happens if they get your LDL down to a certain level. No, that's not what this trial is. It's a trial of a single drug, given the same way throughout the entire trial. Now, this may be more familiar if you look at a trial like Jupiter, but they're all the same. Jupiter said if you had low cholesterol and elevated CRP, then treat with rosuvastatin. Again, a fixed drug trial, not a titration trial, not a strategy trial. But this is the same as all the other cholesterol trials. There are specific inclusion criteria, and then they're treated. Now, it happens that what do you need to know about these trials of statins? And statins are the drugs that we have the most evidence of benefiting patients. If you look at all these trials, you see combining them, pooling them. The statin trials versus placebo, you end up with about almost a 20% reduction in just about anything you look at related to cardiovascular disease, and a slightly smaller reduction in all-cause mortality. That's what you have. No matter what, you get this consistently, you get about a 20% reduction if you give a regular statin. What's interesting is, no matter what your baseline lipid levels, you get about a 20% reduction in risk. No matter where you start. It doesn't matter what your cholesterol level is. If you give a statin, you can reduce risk by about 20%. I think of statins as risk reduction pills, more than I think about them as lipid-lowering pills. Because if I give them to somebody, I can lower the risk by about 20%, no matter where they start. And if I give them a more potent statin or a higher dose of a statin that they tolerate, I can get about another 15% reduction. So with a sort of typical dose, I get a 20%, 17% reduction. And if I escalate, I get about another 15%, no matter what the cholesterol is to start. Where did the 70 come from? Where did the target come from anyway? Well, it turned out in the discussion section of the TNT trial, this figure appeared. I've never seen a figure in a discussion before. It wasn't part of their science. It was part of their discussion. And what they did was they plotted a bunch of the studies. And this is 4S placebo, 4S intervention. And they put all the intervention groups in for the various studies that they were looking at. And they drew a line. And TNT intervention was almost at 70. And the event rate. And so this is where the 70 came from. Is this a study? Now, you want to know what's really funny about this? You could look at it a different way. Take a look at this figure and see if it gives you a different idea about this. Now, how many times have you seen this? Hundreds, thousands of times, right? This is where people are telling you lower is better because they're showing you the trials. And if you looked at the trials, you line them up like that, lower is better. But look here. Actually, every trial is getting you about a 20% reduction in risk. Every trial. If you take the placebo to the intervention, you're getting about a 20% reduction in risk for each individual trial. No one ever took this group and treated them down to this level. Do you see what I mean? No one ever took a 4S placebo group and titrated them down to the TNT intervention group and saw whether or not you produced that much benefit by doing it. Each trial produced only about a 20% reduction. No trial went from 25 to 5. It's an optical illusion. Every trial got a 20% reduction. You can't take the worst one and draw a line to the best one without proving that that's actually what would happen. But that's the optical illusion that was foisted on us. I wrote an article with Rod Hayward, University of Michigan, where we said, if this is true, that these drugs reduce risk by about 20%, and they do so no matter what your cholesterol level is, or that the more intense gets you another 15%, then we should be treating based on risk, not on cholesterol levels. And the patients who benefit most are the higher risk patients. And the patients who benefit least are the lower risk patients. That's particularly interesting in Spain, where low risk in Spain is very low risk. And figuring out who's at risk is very important. And we said a tailored treatment strategy, which means based on risk, prevented more events while treating fewer people with high-dose statins. We could treat more people and treat fewer people and save more lives by concentrating the drug on the higher risk patients. How does that work? Because there's some patients with higher cholesterol, who are low risk. All their other risk factors are low. Or there's some people with lower cholesterol who otherwise are higher risk because of their other risk factors. Concentrating it to the patients who would benefit most has served us best. I just want to quickly go through something that was also interesting to me that I found out this week. Do you know, have you seen this? The European Guidelines on Cardiovascular Disease Prevention in Clinical Practice. It came out last week. May 3rd. That's this week, maybe. No, last week. And this is what they say. Now, the Europeans, can I call you Europeans? Yeah. Okay. I don't know if you belong to this group. The Europeans, I say this with deep respect, have gone the other way. They have full force gone in with targets. This is the newest guideline, out last week, and they're telling you the recommended target levels. In patients at high risk, go less than 100. In patients with very high risk, go less than 70. You may be more familiar. Less than 1.8 millimole per liter. So, everyone, you should treat, everyone should be below this level. The high CVD should be less than 2.5, and the very high less than 1.8. And what do they say? Class 1. Level A. The grade is strong. I don't know what level A means in Europe, but it must mean without trial evidence. I don't know. I'm not a good translator of the guidelines. But I'm very curious about this move. And where do they say statins as first-line drugs? In transplant patients with dyslipidemia, it's 1A. They don't, this is saying, go for the target. It doesn't matter what strategy you use. They're not directing you to use statins. In this recommendation, in the text, yeah, sure, they'll talk about statins, but this recommendation is all about the target and getting there to the best of your ability. How does that contrast with what's going on in the U.S.? Well, you can imagine I've been beating this drum loudly, but others have been joining this perspective. And things are changing. In this guideline, secondary prevention and risk reduction therapy, 2001 update, came out in November, very recent. We changed it. We changed it. And this is, I want to give you a sense of this. I'm going to pull out one of these, but I want to just tell you, okay, so we say lipid profile, lifestyle modification, dietary, blah, blah, blah. Of course, therapeutic lifestyles are very important. But where does it get to be about the drugs? In addition to adequate lifestyle changes, statin therapy should be prescribed in the absence of contraindication or documented adverse effects. Level of evidence A. This is the only level of evidence A. Anything that says about targets in this guideline says level of evidence C, expert opinion. Because finally, we're adhering to the evidence. The evidence says statins reduce risk. And in high-risk people, they should get statins. And if they're very high risk, they should get more potent statins or higher dose statins. That's the evidence. It's not the target isn't the evidence. Now, people can still say, I believe in targets. We should push them down further. You can, but it's not class 1A. There's no trial of it. I want to just give you an example. And we even said in this, I only say we because I was very involved talking to Sid Smith about this, an adequate dose of statin should be used that reduces LDL-C greater than 100. Even when it says target now, it says target associated with statin therapy. And look, level of evidence C. Not because statin, but because statin to titrate. That's expert opinion, because no trial ever studied that. I'm going to finish here with just a few quick slides to give you a sense. This is not just about cholesterol. This is, by the way, very interesting. You've got to believe this is true in hypertension as well. Do we really believe that it doesn't matter what drug you use and it's all about the blood pressure level? Is it even possible? But we've had so few head-to-head trials and they've been so sporadically conducted. Our evidence base is so confusing in hypertension. It's hard to know what strategy is best. But in addition, we have targets that are stricter than what we've even been able to achieve in the trials. This is a complicated slide that's from the European committee. I really commend them. The two colors represent the difference between the intervention group and the placebo group. So for example, here, the placebo group achieved 148 and the intervention group 130. And then they color it by whether there was a benefit or not. So in this case, for example, this is the difference between the two treatment groups. And the 4 studies showed benefit. This study showed no benefit. But look, you know diabetes, don't we have a stricter target for diabetics? By the way, you know in ACCORD also, very aggressive blood pressure trial in ACCORD, they pushed people down to 120 with diabetics. You know the result of that, don't you? No benefit. No benefit. I could have showed that one. Marked difference in blood pressure, no difference in outcomes. But here's the diabetic trials. Remember, this line represents how well they did in getting the diabetics to the level. None of these trials got them less than 130. In my country, at least, we're being told, treat diabetics to systolic blood pressure of less than 130. That's fine. No trial was able to achieve that. Where's the evidence base for it? In the trial we just did that got people to 120, failed, was a negative trial. I'm not saying you couldn't suppose it's beneficial, but it would be your expert opinion. Finally, hemoglobin A1C. I have to show you this because same story. Strong epidemiological relationship. A strong belief that if I move the hemoglobin A1C from here to here, I move them down the curve. You know the story. Accord. I just love this study. Accord. Standard treatment therapy around 7.5 hemoglobin A1C. The intensive therapy. This is, by the way, a strategy trial that titrated medication to get people to a target, less than 7. In the United States, many doctors are being paid based on the percentage of their patients they got less than 7. It was so important that we were being judged by how successful we were by the hemoglobin A1C less than 7. And this trial, bless them, they achieved it. This is not easy to do with your patients. And they did. They got the intervention arm less than 7, down to 6.5. It's incredible. But look what happened in Accord. More deaths in the group that went less than 7. More deaths. They ended this trial early because of harm. But their risk factor looked very good. They just died more often. That's all. Otherwise, fantastic. Now, there were 2 other trials. One in Australia, one in the VA, also in the US. They didn't show harm, but they didn't show benefit either. And when you combine all 3, there's no significant benefit for macrovascular complications. That includes cardiovascular or cardiovascular complications specifically. Now, I looked at this guideline from the ESC. Recommendation. The target hemoglobin A1C for the prevention of CVD in diabetes is less than 7.0%, is recommended. Class 1, level A, grade strong. I'm not making this up. I don't know why they did that. They have 3 trials. People are debating microvascular complications. I can explain to you my view on that. But on macro and cardiovascular, there is no debate currently about the less than 7. Maybe for younger patients. These were patients by and large 65, maybe 10 years of type 2 diabetes. You can believe that there's some benefit, but it would be expert opinion. You could believe that I can still move them down, or that the drugs they used were the wrong drugs, even though in each of the trials they were using different drugs. But it would be expert opinion. So I think this is going to herald a new era where there's going to be an increasing pressure for us to demonstrate not just change in risk, but not just change in risk factors, but change in risk, outcomes that matter to patients. This is unfortunate. Trials are going to be more expensive. Drug development is going to be more difficult. It's great for the companies to get $1 billion drug without having to do one large outcomes trial. But I think it's going to be less common. The cholesterol ester transfer protein studies are an example, I think, of a moving feeling that we need to be able to test it. Still in diabetes, though, we have so many drugs that lower glucose for which there's uncertainty about their net benefit or harm. Hypertension, the same. We're going to move more towards greater accountability. It's going to change, I think, the way we're thinking. I'm surprised at the new ESC guidelines, but I think eventually they will follow what I hope will happen in the U.S. with our new government guidelines, which will be a greater adherence to the actual evidence. If we want to achieve these goals, we have to be accountable for the fact that what we do is actually producing the outcomes that we expect. We can't just believe it. We have to prove it. And we have to see that it's true. Thank you.